originally intended lifespan. Finally, in May.
Good evening, ladies and gentlemen. Welcome to the Pitt County Board of Health meeting. First, I'd like to call the meeting to order, and if there's any public comments, we'd like to invite them right now, and I've been told there's none. First thing on our agenda is the minutes from, I believe it was from June, the June minutes. Everybody's got a copy. I need a motion to approve the minutes from the June meeting.
So moved.
Second.
I have a motion to approve and a second. Any discussion? All in favor?
Let me make one comment.
Okay, go ahead.
For interest of individuals in the future reading the minutes, the last paragraph on the third page has 2 in parentheses, public health nursing supervisors. At the first of a sentence, it should spell it out, TWO. It would confuse some people in their reading. That's sort of being picky, but anyway, thank you, Mr. Chairman.
Okay. Do we want to make them corrections, or
If it's all right, we can amend those.
Amend
with
it?
that correction.
okay, we'll amend it. Still have a motion to approve and second. Any more discussions? All in favor?
Aye.
Opposed? No. Motion passed. Next item on the agenda is a financial report for the year 2011-2012. Mr. Reed?
Thank you, Mr. Chairman, board members. The financial report that you have in your packet tonight is our year-end financial report for the year that ended about 45 days ago. It ended at June 30, 2012. This is a simplified report from what you normally see because we don't have any more timing elements. All the timing elements have been booked. So you'll see in the left-hand column, our budget was a little bit over $10 million for the fiscal year. The revenue that we actually brought in was that $9,737,000. And then expenses against that revenue was about $9.5 million, which gives us a net surplus of about $231,520. And that surplus is without using any of our restricted fund balance. And I'm going to kind of go over how we achieved that, because it was up until about 3 months ago, I thought we were going to use a pretty significant portion of our fund balance to support operations. But if you just go through the top part of the budget of this report, the revenue items, you'll see we budgeted about $1.1 million in Medicaid revenue. We got about $983,000 Medicaid revenue. That was fee for service. The big change is in our Medicaid cost settlement. We budgeted $365,000 for the Medicaid cost settlement. Near the very end of the fiscal year, May and June, we got notification that we were going to get about $946,000 of settlement funds. So that was a positive variance of about $580,000 that we hadn't budgeted for. Typically, I look back over the last 5 years, we received about $518,000 on average of Medicaid cost settlement. So this $946,000 is a significant increase, not only over what we budgeted, but what we have received in the past. One other thing to point out, that $946,000 that we actually received represents 90% of the settlement. They're holding back 10%, not just for Pitt County, but for everybody. And they're going to do what they call a desk audit. The Department of Medicaid. We'll do a desk audit in Raleigh, going over all the information that we gave their staff to come up with this. So they're actually holding back about $95,000. Hopefully, when that audit settles, we hopefully will get all of that too. A real dramatic change from what we've seen in the past. If we move on down, you'll see clinic fees and environmental health fees. Both came in slightly under budget, and we have been talking about that all year long. That was really not a surprise to us. The DHHS receipts, those are state and federal reimbursements for expenditures we've incurred. So you'll see that we actually got about $110,000 less in remittances. However, on the expenditure side, we incurred $110,000 less of expenses. So really, it's kind of a wash to us. The county appropriations, they budgeted $4.1 million. They transferred that entire amount to the health department. Fund balance, again, we did not have to use any of our fund balance. And then the other is our private grants, and again, those are like the federal and state reimbursements. The fact that we drew down about $104,000 less than budget is because we incurred about $104,000 less of expenditures on the expenditure side. So all in all, we're going to, where we originally thought we were going to use potentially $517,000 of our fund balance, we're actually going to not use any of that, actually increase our fund balance by the $231,520, due almost exclusively to that increase in the Medicaid cost settlement number. The next slide here, I did want to give you a little analysis of the fund balance. And as we entered July 1, 2011, the beginning of that fiscal year, we had $813,000 of restricted fund balance sitting on the books, kind of our savings account. We budgeted $517,000, so if we would have used that, we would be going into this current fiscal year, the one that started July 1, 45 days ago, with a little bit under $300,000 of fund balance. And we have budgeted in this current fiscal year $288,000 of fund balance to support operations. So what actually occurred is we still started with the same 813. However, instead of decreasing our fund balance, we've actually increased it by that $231,000. So as of July 1, we have $1,049,000 roughly in restricted fund balance in our savings account. The what if column here is just to will show you if the Medicaid cost settlement had been exactly what we budgeted, we would still only have drawn down $349,000 of our fund balance versus the $517, and it would have gone. We would have gone into this current fiscal year with about $464,000 of fund balance. So the fact that we got such a large Medicaid cost settlement really had a dramatically positive impact on our financial situation going into this current fiscal year. We do have three other programs that the health department supervises that are not in that overall budget, and we've done that. Actually, the county finance department asked us to account for them to help them out in their reserve balance. Technically, it helps them out. So there's a technical reason that I'm not quite sure about, but we're accommodating. But we have the Communities Putting Prevention to Work grant. And that grant is getting ready to wrap up in about at the end of September. It's been a multi-year grant, and we've been working very hard on that grant. We've got a new grant, this Positive Parenting Program. That is a grant from NACCHO, and it's a multi-year grant. We're really in our first year of that. And then we're starting a new grant, multi-county, I think it's a 9 or 10 county grant called Community Transformation Program. These three grants will continue into the current fiscal year. With the Communities Putting Prevention to Work, it will fall away in September. So we'll come back and report more on these three grants as it develops. And Mr. Chairman, that is, as far as the 2012 financial report, that is my report, and I'll be glad to answer answer any questions.
Any questions? Go ahead.
Just a quick question, John. If the 10% of the settlement comes in, is that retroactively applied to this past year's budget? I mean, obviously it's money in the bank either way, but is it retroactively applied and you readjust the numbers, or is it just applied as?
Well, we've never had that to occur, but the books will be closed out before that audit is settled, so it will be a plus to the new budget year.
Okay.
And I certainly have some items that I would like to tag that new funding for coming up in the budget year.
John, along that same line, does this increase in the Medicaid supplement the result of increase in services or only in the increase in the reimbursement?
That's a really good question. And I went back and I looked and I said, you know, our average Medicaid cost settlement over the last 5 years has been around $500,000, like $518,000. And fundamentally, while we have made changes in the way we deliver services and some of the services we deliver, we really haven't had any kind of a large change. So the only thing that really changed was the way they calculated the cost settlement. It was very, very different this year. And I think that's the reason they're holding back that 10% to make sure everything trues up, because it was such a dramatic departure. My thinking is if they would have applied the same standards in previous years that they applied this year, we would have got more Medicaid cost settlement in the previous years. I think the reason it's increased is the way they're calculating the settlement versus the way we're conducting business.
Along that same venue, have you got a way, or do you track apples to apples and oranges to oranges as to service, as to comparison? Are we doing more services in the clinic that produce or higher revenue stream versus spending more time on lesser involved services?
I think what we've seen this past year in 2012 was we have had some staff shortages. So I think we probably have been a little less efficient in our clinical operations, which interestingly enough will drive up the cost settlement, which doesn't, intuitively make sense. But I do have all the cost settlement documents, and one of my plans is to kind of go back and try to ferret out what's driving that difference. But it's a really complicated mechanism to look at.
I would be very interested to see at least a 3, maybe to a 5-year profile
Right.
of what we're delivering as to the effectiveness of what we're delivering versus to the effectiveness of the reimbursement profile of that.
Right. We will try to ferret that out for you. I mean, it's certainly something I want to get my arms around because of the dramatic difference in the amount of the settlement. It keeps you awake at night a little bit. If you don't know what's driving that change, at least it keeps me awake at night a little bit.
Dr. Taylor, I'd just comment on that. I think you're right. We are very interested in whether or not we're improving our services, improving the efficiency of those services, and improving the capacity of those services. So we're busy at trying to make sure we're doing that. As John mentioned, we've had staff shortages. We are hiring some staff right now. We've done some significant changes in the operations of the clinic just in the last couple of months. So I think those things are improving. In terms of the cost report, the state used to settle for all the health departments as a group, and this year that went away. And part of that was they used a consulting firm to do that data, manage that data. And so they did away with that consulting firm. So that was a big cost right there that money now can come to health departments directly. I would just let you know that there are health departments who saw decreases in their Medicaid cost settlement recently.
Total,
Yes,
not.
compared with previous years.
Yeah.
So they saw theirs go down, where Pitt County saw its go up. And we're being settled on an individual basis now instead of a group basis.
Yeah, that's why
So-
I'm interested in okay, are we gonna spend 90% of our time doing ear swabs at a cost reimbursement that is non-productive? Should we be having our staff do things that should not be done at the health department at the rate that their reimbursement, but only for a select number of people that cannot get that service anywhere else? And if it is no longer prudent for us to be doing massive inoculations for influenza, and the drugstores seemingly are trying to get into that venue, then why should we have staff assigned to doing that when there isn't a need? I'm just watching and looking for
Absolutely.
the productivity versus the cost relationship benefit to what our trained staff should be giving to the public that we're trying to serve.
Right, absolutely, agree. I would just, the other thing I'd add is that, and I've mentioned this in the past, but there is a likely possibility that the cost settlement for Medicaid will completely go away within the next few years. So that's something else I think we need to keep on our radar screen.
You had a question?
Yes, an opinion. Knowing what I know, Mr. Reed, you're gonna have to be real smart to get any more money from the state of North Carolina. They're gonna try their best to take every bit of it. That's my opinion.
Any other questions or comments? Okay, next
I
item.
would need an action to approve this report
Oh, you need an action to approve the 2000,
in 2012.
So moved.
Second.
I have a motion to approve in second. All in favor? All opposed? Approved. The next item is a debt write-off. I think you're going to handle that too.
Yes, sir, thank you. The bad debt write-off policy for the health department, I've kind of outlined it here, a few bullet points. But an account's considered uncollectible when there's been no activity on that account for 24 months. That means there's been no payment on the account, we haven't seen the client, it's been on the books, we haven't had any activity whatsoever for at least 24 months. Our policy also says periodically we will have an itemized list of uncollectible accounts and prepare those for the health director's review, and then we will bring that to this board, ask you to write off those accounts. We wrote our policy where it says periodically an itemized list as opposed to annually or every 2 years to give us some flexibility in when we're going to do that. So I wanted to give you, as of the end of the fiscal year, this was the aging of our receivables, and you can see the bulk. We have about $329,000 of receivables on the books. 314,000 of those are more than 30 days past due, and what you're going to see here is that about 200,000 of those are actually 2 years past due. The last bad debt write-off we had was 3.5 years ago, and that's the length of time between that bad debt write-off and this is far too long. I have to take responsibility for that. I have an aversion to writing off debt. That's my own philosophy. But we do need to write off some debt. I am requesting, and in February, 3.5 years ago, we wrote off $190,000 worth of client accounts. We're requesting $206,518 of accounts be written off. That represents 1,860 accounts with an average balance of slightly over $111. All of these accounts have been, if we have all the information we need to put them with the North Carolina Debt Set-Off Clearinghouse to try to collect when they file their taxes or they win a lottery, they have gone through that cycle at the minimum 2 times, haven't filed a tax return, haven't won the lottery, so they're really just out there. And these, we mail out statements quarterly. So by writing off these 1,680 or 1,860 accounts, we're going to save about $4,000 in postage annually. If, however, after we write those off, they don't just disappear, we'll keep them. So if that client comes back to the health department to get a service, that account gets active again. We'll put it right back on the books and try to collect again. We have the policy of not denying services to our clients if they don't have the ability to pay. And that really is what drives this. And especially in the last, I would say, 18 months, we have seen more and more clients who just do not have the ability to pay. So, Mr. Chairman, I'm asking for this board to approve this write-off, and then we will take it, with this board's approval, to the Board of Commissioners.
I need a motion to approve the debt write-off.
So moved.
Second, anybody?
Second.
Any discussions or further discussions?
I would like to ask is if the clients, or in the past to your knowledge, if any of the clients come and ask for forgiveness, or are they completely ignoring the situation altogether? Are you aware of that?
I don't think I quite follow the question.
If someone new or comes in and says, I know, or they are informed that they have an indebtedness to the health department, is there a mechanism which they could say, I'm having hard times, and acknowledge the fact that they can't pay, they know they haven't paid? Is there any some documentation? I think as a private business person in the past, I've run into situations where I've written off
Right.
debt, and it, I guess from a moral standpoint, or from the point of view of saying, okay, I know you're having hard times, but at least the person acknowledges
Right.
and asks somewhat of forgiveness of the debt, as opposed to being a blatant debtor. I have trouble with people abusing the system, as opposed to someone saying, I'm having hard times.
In those cases, what we try to do, we don't have the authority, without this board's approval, to write off any debt. What we do in that case is we will set up a payment plan with that individual. And that might be as much as, hey, I can pay you $25 a month or $5 a month. If they're making any effort to do it, we're going to work with them as much as we can. And our folks in the business office are pretty cognizant of that. They're very empathetic, and they obviously realize. So we do try to have a payment plan with them, and it can be, it can be as little as $5 a month.
Any more questions? You had a
Yes, I have
question?
a question. If there's $206,000 sitting out there, it costs us $4,000 a year to try to collect it, and we're not really collecting it within that year. So essentially, we could have spent, if it's been 2 years, $8,000
On those
trying to
uncollectible accounts.
collect that.
Correct.
If the debt doesn't really go away, as in if they come in, we can reactivate it, wouldn't it be in our best interest to stop taking so long in keeping the collection process going when it's an expense for us? We may not
Correct.
collect anything.
Absolutely. And that was the point I made. It was far too, 3.5 years is far too long
Okay.
of an interval to write off bad debt.
So,
And I have to wear that, I'm
yeah.
afraid.
I mean, even though it says periodic, I mean, is there any way for us to look at it annually?
Absolutely,
Okay. And then hopefully cut our losses
absolutely,
in
Absolutely.
the long run.
absolutely. We do like to at least try to have them go through that North Carolina debt set-off at least twice.
Is that's 2 years?
Yeah, to give us
Okay.
two shots at that.
Okay.
Okay, I have a motion and a second. And any more discussions? All in favor?
Aye.
All opposed? It's
Thank you,
approved.
Mr. Chairman.
Next item on the agenda, annual communicable disease report. Dr. Marr, I believe you said you were going to do this.
Did you do that?
Hit a wrong button.
Let's see, actually, I think I do it from down here. Yeah, here we go. Okay. Thank you, Mr. Chairman. This is our communicable disease report for the year, and I'm going to share some statistics with you tonight. I've got most of this will be for 2011. Our statistics are a little bit behind. It takes us a while to get all this data together and to tabulate it and analyze it really before we are ready to do this. But this is part of our requirement also for our accreditation process. So I think it's important, and it's something I think that we should share with the public, so I'm glad we could do it tonight on televised Board of Health meeting. Just an overview of our communicable disease programs. Our goal is to interrupt the transmission of communicable diseases with appropriate prevention and treatment. This is really the basis of public health that started 100 years ago. This health department now is in its 95th year as Pitt County Health Department. So we've got a long heritage of controlling communicable diseases in the community, and this is the thing that most of the public relates to when you mention public health. And we do that through all kinds of programs, whether it be through women's and children's health, through our clinical areas, as well as our environmental health programs. Are all about control of communicable diseases and interrupting that transmission. Just to ground you, our laws, North Carolina laws, give us the authority for this under Chapter 130A, Article 6 in communicable diseases. That's where you'll find the laws that deal with things like who should report communicable diseases, what is the role of the Board of Health, what is the role of the health director, our isolation and quarantine authority, things like that. I also want to tell folks that we collect data on communicable diseases. There's over 70 diseases right now that are reportable by law in North Carolina that we deal with on a daily basis, or a good bit of them we deal with on a daily basis. But we don't deal with all diseases. So some folks want to know why we can't find out what a certain disease was that their child had, or someone that got sick. Why didn't we know what it was? And that's because number one, they're usually not tested because it's sometimes complicated, and number two, they're not reportable. So if a physician finds a particular disease is not reportable, we won't necessarily know about that at the health department. So some of the reportable communicable diseases include the sexually transmitted diseases, and then airborne diseases such as tuberculosis, foodborne diseases like salmonella, arthropod-borne, that includes your ticks and mosquitoes. That's Rocky Mountain spotted fever and West Nile virus, which is a mosquito-transmitted virus. Bloodborne diseases such as hepatitis. And then we also investigate outbreaks where we don't know what it is, but there are a lot of people getting sick. So, hepatitis is one that, hepatitis B in particular, we're concerned about. This is one that takes a lot of time from our staff. It's often difficult to track these cases, to work them up. We get a lot of reports because people who donate blood often will be found to be hepatitis B positive, or a routine blood test that's done at the physician's office will get a report on. So public health is the one that has to track that down to find out, is this hepatitis B case a concern for public health? Where does this person work? Are they a carrier? Some of the hepatitis B cases become carriers, so they can continue to transmit the disease, and those are the ones we worry about. But this is a serious disease. It causes severe liver disease, including liver cancer. It kills 5,000 people in the United States on average every year. It's both blood and sexual transmission that we're concerned about. And 5 to 10% of those folks that get infected become carriers. So those are the ones we're really particularly interested in. Thank goodness there's a hepatitis B vaccine available now, and that's given right at birth for most children. So we've seen the rates of hepatitis B drop significantly over the years. recently. And these are our hepatitis B rates since 2008. You can see there the acute cases in 2011. We had 6 acute cases, 11 chronic cases, and 8 suspect cases. Those suspect cases often take a lot of work in all these diseases because we have to figure out, get information, find out, is this a case or not. I've got a lot of slides, so I'm going to try to move through these fairly quickly because I don't want to hold you too late tonight. Hepatitis C is something that has been around a long time, but we haven't been able to test for it. And we've just recently expanded hepatitis C testing here in Pitt County with a special grant called PIXI grant, Program Collaboration and Service Integration Grant. We were fortunate to get one of the 4 grants of that in North Carolina through the CDC, and it's allowed us to do more hepatitis C testing. The state also plans to expand their hepatitis C testing in their laboratory in Raleigh. But you can see in 2011 that we had 3 acute cases of hepatitis C and 10 chronic cases. Foodborne diseases, this is something that is extremely difficult to track and extremely underreported. There are literally thousands and thousands of cases probably of foodborne diseases each year. We're getting better at diagnosing these. We're getting physicians' offices better at getting stool cultures and other tests done that we need to find out what exactly is causing these diseases. But some of these, I'm sure probably all of us have had a foodborne disease at one time or another in our life. And if you haven't, you probably will before you leave here. Not this building, but leave this earth. But the causes are typical, and these are the things that our environmental health folks, food and lodging staff, deal with every day in inspecting our restaurants and other facilities everywhere that sells food or serves food, like our hospitals and nursing homes and other places, daycare centers. The diseases are acquired by not washing fruits and vegetables. Lack of good hand washing is very important, not only just for the people preparing the food, but also for those that are eating it. Undercooking the food and improper storage is also a big problem that we see. Some of the foodborne diseases that we've dealt with in the last year, this is Campylobacter. You can see we had 15 cases of Campylobacter in 2011. That's a little bit of an increase, not a huge increase, but that's something that we see from year to year routinely. Salmonella is also another one there that we've got 23 cases in 2011 with 2 suspects. And salmonella can present very different strains of salmonella that we'll see, and sometimes you'll see large outbreaks that are associated with like a product that's distributed nationwide. Sometimes we'll have salmonella outbreaks. We had one a few years ago with peanut butter and some of the vegetables. We've been having outbreaks of salmonella here recently too. So some of these are local outbreaks that you'll see like in a daycare center. Other times it's a national type outbreak that we'll be involved in because of the distribution of the product. Shigella is another one that we deal with. Often affects children. We had 3 cases in 2011 with no suspects, so not too bad for Shigella last year. Tick-borne diseases or arthropod-borne diseases, these are ticks. Ticks have been pretty bad this year, and we're likely to see, I think, our 2012 rates of tick-borne diseases going up here in North Carolina. 3 that we monitor routinely are Rocky Mountain spotted fever. That's sort of a misnomer. Rocky Mountain spotted fever is not near as prevalent in the Rocky Mountains as it is right here in North Carolina. We've always been the capital of Rocky Mountain spotted fever. Lyme disease is sort of new to North Carolina. Started in Connecticut and has worked its way down the East Coast and to other parts of the country. But we are seeing some Lyme disease here in North Carolina, as well as ehrlichiosis, which is another one that most people haven't even heard of yet. These are the statistics for the last 3 years on those diseases. You can see we had, these are cases and suspects. So in 2011, we had 6 cases of Rocky Mountain spotted fever here in Pitt County with 31 suspects. 1 case of Lyme disease out of 22 suspects, and no ehrlichiosis was reported. again, these things often are not reported, so the statistics we're looking at are just the ones we know about, not the other ones. And just a reminder, things like Lyme disease, a lot of people may actually contract or be infected with a disease like this and not get that sick. So they may not even get to a doctor's office to get reported. Our immunization program, we're very proud of. You mentioned our flu vaccines a while ago, Dr. Taylor. We have cut back on those large flu clinics that we used to do as a result of all the drugstores offering influenza vaccine, and the new influenza vaccine for 2012 is already out, I understand, at a lot of the drugstores. So folks should go ahead and get those vaccines soon. And I want to talk a little bit more at the end of this presentation about the H3N2 variant flu that's been in the news lately. And Dr. Ramsey, if you have information on that, I hope you'll share it. But our goal with immunizations, particularly childhood immunizations, where we know are so important because we want to get those children that are protected. And we have to do this age appropriately before they even get to, a lot of these children are going to child care centers very young as infants, so they're going to be exposed to a lot of diseases, and so they need to be protected. You know, we can't wait until they go to the public schools to get them protected like they did years ago. We've got to have these children protected from birth, really, like with hepatitis B and with pertussis, which is another one we're seeing an outbreak of in the country right now that can kill children, particularly young children. And a lot of folks have today. A lot of our parents weren't alive when there were large outbreaks of these communicable diseases that are now vaccine preventable. And so some of them don't appreciate the value of vaccines as much as they used to. But our goal is to have every child in the county appropriately immunized by age 2, and we're striving to do that. You can see that of the folks that come to the health department in 2011, our rate for that was 90%, which is the state goal. So we've met that state goal, and we're proud of that. Overall, the county rate is not quite as good. It's 72%. We're working with Pitt County school nurses, the public and private schools, daycares, after-school programs, the Pitt County physicians, and I have to say our physicians here are just great in terms of getting these things done. A lot of our pediatricians have rates that are close to 100%, so they're doing an excellent job. The fact is that a lot of children just don't get to the doctor, and so that's part of our problem is identifying these children. You have children coming in, children going out as people move. So we're doing all we can to make sure that we find these children. I will say that because of our staffing shortages, we've cut back in the immunization area. We used to have a nurse that would really track people who were not up to date on their immunizations. We haven't been able to afford to do that this year, and it goes back to what you were talking about, Dr. Taylor. We had to set priorities, and that was one of the things we cut out about a year ago, and so we've had to cut back, but it's something we think is desperately needed and very important, but we had to cut somewhere. Future immunization program goals. So this is with Healthy People 2020 objectives. These are our national objectives. By the year 2020, we want to increase the age-appropriate immunization level of all eligible 2-year-old children served by the health department to 89% or more. You can see we've already exceeded that. By year 2020, assure that at least 95% of North Carolina children are represented in the North Carolina Immunization Registry. Now, we were one of the pilots for the Immunization Registry, and we have done a great job of getting our providers here in Pitt County on the Immunization Registry, but we've still got a long way to go in terms of having everybody on that Immunization Registry. But we're coming along very well, and the folks that have joined that have really appreciated being able to get their vaccines updated. You know, folks can move here from out of state, and they can have instant access to their immunization records when they need them for employment or for schools and things like that. So it's really been great to have that registry. By the year 2020, increase the age-appropriate immunization levels of all eligible 2-year-old children residing in Pitt County to 71% or more. We've just met that one at 72% last year. So, but we think we can do better than that, and we'd like to see that closer to 90% someday. We hope we can get there. Some of the outreach efforts that we have been able to do this last year include our annual maternity fair that's held at the convention center every year with pregnant women, and also with expecting folks who are planning pregnancies in the future often come to that, and then folks with young children often come to that. So that's a great place to give the message about the importance of immunizations. Our annual influenza campaign that we just spoke about, the Project Homeless Connect event that was done by the county this year, county and city, and a lot of partners came together for that Project Homeless Connect. We were there also providing immunizations. Evening clinics for back-to-school shots, so we're running special clinics for school children that may be behind on their vaccinations when they do get to school. And then when we manage those outbreaks, we're also out there doing vaccinations like we did with pertussis. Our STD, or sexually transmitted disease objectives, are to monitor the STD rates and trends in the county, ensure adequate treatment is given to all the patients that are seen not just at the Pitt County Health Department, but also anywhere in Pitt County by private and public providers as well, and report to the state CD branch and eventually to the CDC using the North Carolina electronic disease surveillance system in a timely fashion. And that has been a lot of work. That's another area that we sort of piloted for the state in some areas. Tammy Dubray, our communicable disease supervisor for a number of years, really has been an expert in that area, not just for Pitt County but for the state. Tammy just retired. She worked her last day last week, about a week ago, so that's a big loss for us, but we wish her the best, and hopefully we can she'll stay here in Pitt County, so we'll still experience or have her experience to use when we need it, I hope. Just looking at some of our sexually transmitted diseases for the county, these are since 2007, and I just want you to notice that we are trending up in all of these diseases. Of course, our population has also increased. These are case numbers, not percentages or rates. But you can see that we've got 1,957 cases of chlamydia in 2011, 300 cases of non-gonococcal urethritis, and 611 cases of gonorrhea in 2011. And I should mention that our chlamydia rates are more than twice that of the state rate, which is not something we prefer to be known for. Break that down by sex. Most of these are in women, you can see, and with chlamydia, and that is partially reporting because most of these women are getting chlamydia from men and getting the other gonorrhea and non-gonococcal urethritis likely from men. But men are not as likely to get tested as women. But you can see, nevertheless, that we are seeing an increase just from 2010 to 2011 in both males and females. By race, there's a large majority of these cases are among our African American population, and that's historical, but something that we're very concerned about and certainly want to do away with that disparity as we decrease these rates. This is a breakdown of the same diseases by age, and you can see that at about age 15, those rates really take off as children become sexually active, and they stay up there pretty much through age 30 to 40 years of age. The sites in the county that are reporting our STDs, you can see there's 30% of them are done right at our health department, with the hospital close behind. That's mostly the emergency room where those are done, but also in the infectious disease clinics where Dr. Ramsey works. The private physicians are 17%, and then that 14% is both the ECU campus and the infectious disease clinics. 5% is OBGYNs, and those are private providers also for the most part. And then pediatrics represents 3%, and then other 6%. HIV, AIDS, and syphilis, again, we've seen we saw a decrease last year in our numbers of HIV reported, but we did see an increase in AIDS cases last year, which is a little unusual, and an increase in syphilis. This year, or excuse me, 2011, those rates went back up. The HIV rate went back up to 40, where it was in 2009. So this is still a disease that we're very much concerned about. It's spreading both through the heterosexual and homosexual community, and is, as we often see, syphilis precede an outbreak of HIV, so that an increasing rate of syphilis sometimes just precedes the outbreak of HIV. So we're very concerned, and the state is very concerned about this also, and that Pixie grant I mentioned earlier is helping us work on some of this. Tuberculosis, a lot of folks heard about our case of tuberculosis at the Aiden Grifton High School. I want to talk a little bit more about that in just a minute. But tuberculosis is another disease, historically it's been in eastern North Carolina for many years, and hasn't gone away. We still see homegrown cases. A lot of the tuberculosis around the country has been shifted from homegrown cases to immigrant cases as folks have moved into different areas around the United States. We're still seeing homegrown cases, and the outbreak at Aiden Grifton High School was a homegrown case. So this is a disease that can go on for many years. Folks that may have been exposed when they were young become reactivated when they get older and their immune system slows down a little bit, and then they can easily spread that to their community, to their household members, and others. So something that we take very seriously. So you can see here, these are some of our goals with tuberculosis in 2011. Cases with an initial positive sputum culture had documentation of culture status every 2 weeks until microbiologic conversion to a negative was achieved. The goal for that from the state is 85%. We only did 50% in 2011, and that was really 2 out of 4 cases that we were able to achieve that. Just moving on, the TB cases placed on directly observed therapy, we did much better with that, meeting 100% of that goal. High priority contacts identified received a tuberculin skin test within 1 week. The goal is 85%. We exceeded that at 100%. High priority contacts were identified, were fully evaluated. The goal 85%, and we again did about 50%, 54%. Medium priority contacts identified received a tuberculin skin test within 14 days, and again we did an excellent job of that. High priority contacts over 5 years old who began treatment for latent TB infection completed treatment. We did a very good job of that. All persons who began treatment of latent TB infection completed treatment. That one's much more difficult, and I can tell you that a lot of these folks are difficult to track. They sometimes don't have telephones, have addresses that change frequently, and sometimes just leave the county. So we do the best as we can, but it's a difficult job to do this. The last goal there, all TB cases that had HIV results recorded in their medical record, we almost made the state goal at 83% on that. This is the Aiden Grifton High School TB investigation. It's just to take you back, we had a positive case of tuberculosis. This was not just an infection, but an active disease. Student at the high school that was identified in early June, and this was right before school was about to let out. So we had to act very quickly to make sure that this disease did not spread to others. There were 847 possible school contacts. Just in the first day of testing, we did 758 of those. Since later, we had identified 95 additional contacts, transfers, dropouts, etc., that were notified by letter. Only 2 of the close contacts had what we consider positive PPDs for most folks. So that's greater than 15 millimeters. We had 21 PPDs. That's the tuberculin skin test that was done. Read between 2 millimeters and 40 millimeters, which represents a reactive rate of 2.7% of the population, which is not very high. So that was good news for the school to say that looks like not many people were infected. But I want to really reemphasize to folks that this was early in the case of this disease, we think, and it's critical that we do subsequent testing, do additional testing, because if people were exposed right in that week before, say, the end of May, they wouldn't have a positive skin test. We wouldn't expect them to have a positive skin test for up to 2 months later. So that's why it's so important that we get back to the high school soon, and we'll be doing that next month, to repeat all these skin tests and make sure that all these folks really were not infected, and that second skin test is the one that really is important. So we had 2 positive reactors out of 135 close contacts, and that was a 1.5% positive rate. That's very low. We did 41 blood tests or QFTs, and those were done in special situations where someone the skin test couldn't be used for medical reasons. It couldn't be used for one reason or another, because of like BCG vaccination, which is something that some of the military folks get BCG when they're in foreign countries. It's a vaccine against tuberculosis, and some of the children that are born in some foreign countries also receive BCG vaccine. So in those cases, we use the blood test to test those. And 3 of those blood tests were positive for tuberculosis exposure. That means that folks have antibodies against the tuberculosis germ, not necessarily that they're infectious to anybody else. We did 13 chest x-rays. 6 persons have been started on latent TB infection medication so far. So if we find people who've been exposed, they have positive antibodies against tuberculosis, we know that they've been in contact with the TB germ. They may develop TB disease in the future, and so we offer those folks free medications and monitoring, and that's latent tuberculosis infection treatment. And so, but people don't have to take that. That's totally their choice, so it's up to them whether they take it or not, because at this point they're not at any danger to anyone else they come in contact with a latent infection. So we had more than 150 graduating seniors that need to be retested. So it's not just the folks that'll be in school this fall, but the ones who left that we have to keep track of too. And the health department is notifying these colleges and universities and other places that these students have gone off to make sure that that they are non-infectious and not going to put anybody else in the public at risk of contracting tuberculosis. We do plan to rescreen the remaining faculty, staff, and students in early September, and I think we've got a date on that. I believe it's September the 10th, but I'll have to double check that. And we were talking with the school staff about when the best time for them would be. But they have been really cooperative in this whole investigation. We really want to thank them, and also a lot of the folks from like our school nurses have been very helpful in performing this investigation. And but you can see that it only takes one case of these diseases for a huge amount of resources to have to be pulled to deal with it. And so an ounce of prevention is worth more than a pound of cure. It's worth many pounds of cure. And so we want to make sure that we keep folks, we don't want just one more case of tuberculosis or one more case of pertussis. Tell you a little bit about the pertussis case we had in June. We had one child. That one child had been in 2 daycare facilities. And so we had 42 people exposed. 26 were children less than 5 years old, plus the staff. We treated all of these folks with a lot of help from the other providers in the community. With our physicians, again, are just great when things like this happen. We can call our pediatricians, our family docs, and folks at the hospital. And just all around, they've really been exceptional in terms of helping us get these kinds of outbreaks under control and to do it quickly. So we did this on a Friday afternoon, very short notice, and as usual, things usually happen about 5 o'clock on Friday afternoon. But 18 of those folks did require updates on their vaccinations. So again, these are the kinds of, goes back to our immunization program. If we had that nurse out there tracking, looking for these kids that are not immunized, we may have caught those 18 and may have been able to stop this pertussis outbreak from ever occurring. So that's the kind of thing we try to do. And I'll stop with that. I'll be glad to answer any questions. I know it took a lot of time, and but it is important information, I think, both for our board and for our public.
Go ahead.
Is the state of North Carolina coming forward with any additional money to cover these critical issue situations?
No, not state money, I'd say. We have, like the Pixie grant I mentioned, we've been able to take advantage of, but that's CDC funding. So the state funding is not increased. And the General Assembly just left last month, and we're not expecting any significant increases in these areas, at least. There may be some additional funding in chronic diseases, I think, more likely.
Thank you.
Any more questions?
Are there any focus areas for the Pixie grant that you've received? Can you give us a little bit more information on
Yeah.
what you're going to be doing with
It's
this?
the sexually transmitted diseases, hepatitis C and tuberculosis, HIV, STDs, TB, and hepatitis C.
Okay. So are you going to use some of those funds to have more focused efforts in the population where the numbers are the highest?
We are. We're trying to do several things there. And one that I had a discussion with Dr. Kearney with the Department of ECU Public Health. He's interested in using some students to do some testing of migrant farm workers. That's an area that I think the state is interested in. I tried to get an answer to that last week, but I haven't been able to get up with the physician at the state who will be able to okay that or not. But we're hoping to get out and do some migrant farm workers. We've done some testing over at ECU on campus. Some of those data I gave you were from that tonight. So we're looking at other areas that we can really focus in on to get the high-risk populations for those diseases.
So your migrant farm workers are one of your high-risk groups. For your STDs, where's your high-risk group there?
Tuberculosis and STDs, we're hearing that migrant workers are at risk there. STDs including HIV also. And I'm sorry, your question was, were there other groups?
Yeah, yes.
Men who have sex with men, particularly with HIV, syphilis, and folks with multiple partners, IV drug use for HIV infection, as well as folks who are in the sex trades or using sex for drugs, those types of things. Those are real high-risk populations. Hepatitis C is different. So we're seeing we're still trying to identify of the testing we've done for hepatitis C. We're showing very few positives. So I think we've got to focus better for that disease.
I have a question, Dr. Ramsey.
Just comment and to amplify, we have had a recent meeting between infectious diseases, the emergency department physicians, and Dr. Morrow and his staff about how to improve the follow-up of patients identified in our emergency department and at what was MedDirect of those diagnosed with one of those sexually transmitted diseases. We've recognized that there's some difficulty in following up. As Dr. Morrow mentioned, sometimes folks either don't have good address information or cell phone numbers. So we've had one meeting, and I'm sure we'll have more to attempt to increase to it. So part of the identification is that these new molecular tests are more accurate. I don't think that's I don't think we're falsely finding. I think there is an increase overall, but some of that may be accounted for by the improved testing that's going on with these new molecular tests that are being used routinely now.
Yeah.
Any more questions? This is an action item, correct? You need
Do need approval for that.
I need a motion to approve the communicable disease report.
So moved.
I need a second.
Second.
Any more discussions? All in favor? All opposed? Okay, that was for the annual communicable disease report.
Mr. Chairman, I did want to also mention the influenza
Go right
issue
ahead.
real quickly. I was on a conference call today, this afternoon. The state held a conference call on the H3N2 variant influenza. This is a swine flu that's mostly in pigs, but it has been identified recently in at least 3 states, Indiana, Ohio, Hawaii, and I think there's one more. I can't remember which it is, but there are a number of cases. There were about 12 cases last year of this. There are 150-something just in the last few weeks. All of those cases so far have been in some way connected with swine, so they've had contacts with pigs. The state is concerned in monitoring for H3N2 variant. This is not the H3N2 flu that's in our normal vaccine. It's a variant or swine strain of this. So far, it looks like it's a pretty mild disease, typical of just like a seasonal influenza. So there have been no deaths, and so far this year at least, they're not showing any human-to-human transmission, but the potential for human-to-human transmission is there, and so it is a new flu that needs to be closely watched. The vaccine that we have this year does not provide adequate protection against this flu, so sort of like the H1N1 that we had a few years ago, we may be looking at a second vaccine if this becomes a problem in the near future. But the vaccine is already under development, and actually has been developed, I think, so it's already under testing at this point, should it be needed.
But how long does it take for that to come to the public before they can actually get it? 6 months?
No, it
less?
won't be that long. Yeah, I think they can produce it pretty quickly.
So they're not doing it in eggs?
Right. Or they won't. I don't think they will be doing eggs with this vaccine if it's needed.
Okay. Next on our agenda is a new business, election of a vice chair for the Board of Health. At this time, I would like to entertain some nominees. Ramsey?
Dr. Mark Hayes.
Anyone else was for some nominees? Okay. Any discussion on? I'd like a show of hands on a vote for this. All in favor for Dr. Hayes as vice chairman, please raise your hand. Okay, we have all in favor. Dr. Hayes will now be our vice chairman. I guess we'll inform him of that. Next on our agenda is the health director's final report.
And I make it a very short report. I did want to, John Reed mentioned our 3 grants that we have right now. The Community Transformation Program grant, that is a 9-county grant, and we're the fiscal agent and lead for that project here in those 9 counties that surround us, or that includes Pitt. Also, Triple P, or Positive Parenting Program, is just getting going. And Nurse Family Partnership just had their first graduation that follows high-risk first-time moms through the second birthday of the child. And so they had a recent graduation that went really well. The program is expanding, so I think we're real pleased with what's going on there with all of these grants. The only other thing I just mentioned real quick, there was a great article on Joe Morgan in the North Carolina Medical Journal that just came out, so I'll get a copy of that, and I think I sent that to all y'all via email. So we're very proud of the work Joe's done.
Okay.
We did have some other staff that retired last week, so it's been a little bittersweet the last couple of weeks of seeing some longtime staff leave. But we also have some openings, so we are hiring some new staff with the CTP grant program. We've just hired 2 new staff. And we'll hire probably 1 more at least into that, and we've gotten some other of our vacancies filled just recently. So,
Well, that's good.
Of those vacancies, are any of those county positions?
the question was, are any of those county positions, John? I think so.
Several of those
Yeah.
positions that we are, have
Interpreter.
just opened up that we're recruiting for are recently hired, are county-funded positions, yes. And in some bare areas that we really, needed people, so yes.
So the county manager is listening to your request.
He is. Not all the time, but a lot of the time. he is.
Okay, any other words of wisdom today, or? I need a motion to adjourn the meeting.
So moved.
All in favor of the motion? Second it to. Meeting's adjourned.